Welcome to the next episode of Doc is In. My name is Dr. Fawad Khan, and I work as section head and medical director of longevity medicine section in the Cancer Center at Cleveland Clinic, Abu Dhabi. Today, I'm very excited in welcoming our two guests, our genetic counselors from our genetic counseling program, Leah, Abed, and Rifaat, Rawashdeh. And we'll be focusing today on role of genomics in precision oncology. Welcome, Rifaat. Welcome, Leah.
Thank you, Dr.
Thank you,
Fawad.
Doctor.
So, Rifaat, if we may start with you as the first question, what is germline genetic testing, and really how does it impact the clinical care in our oncology clinics?
Sure. Thank you so much, Dr. Fawad. And I'm really glad to be here, and thanks for the opportunity. So basically, germline genetic testing is a specific kind of testing that is offered for certain types of patients who meet certain criteria. And it mainly focuses on testing your DNA that you were born with, okay, from a sample that could be either a blood sample or a saliva sample. And it looks for inherited alterations or errors in your DNA or specific genes. And those are known to be associated with increased risk for certain kind or kinds of cancer, including like breast cancer, colorectal, ovarian, and so on. And this kind of testing is considered to be a cornerstone of precision medicine. And it's different than other kinds of testing like tumor testing, for example, because it focuses on the DNA that you were born with. And we know it is inherited because it can be passed on from parents to their children. Okay, and it also impacts the treatment or the management plan for patients based on the result. And that could be summarized briefly into enabling physicians into the clinic, into providing the best treatment, selection, or into some surgical decisions, or even for increased surveillance and future prevention for our patients. In addition, that because this is also can be, as we said, inherited, it has also implications on other family members, so it can enable testing of other close blood relatives for that gene mutation, which could inform their management as well.
Thank you, Rifaat. Very informative. Leah, if I could ask you, how do you select patients for this type of germline genetic testing? Surely there would be some patients would be higher risk, or certain cancers would be more important from germline genetic testing perspective. Can you share some details?
Absolutely, Dr. Fawad. Thank you so much for the lovely introduction. First of all, I'm very happy to be here. So as you perfectly said, of course, we do not test for germline testing for every single patient who comes into our oncology clinic. We do look for certain criteria, obviously based on international guidelines that do help us decide who are the patients who are eligible to be tested for germline genetic testing. So, because as that is known to some, is that only 5 to 10% of the cancers are linked or are known to be linked to this day to germline genetic variants. The other cancers that are also can be common are not necessarily linked to a germline variant. So this is why we cannot really test, or we do not really necessarily test everybody. So these criteria are mainly the types of cancers. Of course, there are some kinds of cancers that we do can raise more red flags than others, let's say. So for example, breast cancer, ovarian cancer, prostate cancer, pancreatic cancer, colon cancers, and multiple others can lead us in a way, can guide us to say, okay, this type of cancer can be more linked to a germline variant. The other thing we look at is, of course, the age of onset. Is it a young onset cancer? Of course, the younger the age, the more red flag it raises. And of course, something that we do very commonly in our counseling clinic is that, of course, we look into the family history. We look, is there multiple cancers in the family? Is it on multiple generations? What is the age of onset once again? So all of these combined can help us assess whether the person in front of us needs or is eligible for germline genetic testing or not. Of course, things are evolving, and we are beginning to test more and more because we have more access to genetic testing. And as an initiative that has been also local is the DOH, or Department of Health initiative, which basically started a study to do the genetic testing on the general population of Emiratis, a certain sample of Emiratis that are being tested with not necessarily any cancer or any family history of cancer, to basically see the need of, is there a need to test people from the general population without any necessarily red flag in their personal history or in their family history.
Thank you, Leah, and thanks for touching upon the Emirati Genome Program, which is really a unique program of population screening on a global stage, probably the largest of its kind given the population size.
Absolutely.
And I wish we had more time to talk about that. Probably we'll have to do another program on that one. Rifaat, coming back to you, the germline genetic results, how do they help our surgeons and our medical oncologists in deciding the treatments for our cancer patients?
Absolutely. Very important question, Dr. Fawad. Thank you for that. So basically, germline testing, or cancer genetic testing, basically offers a unique opportunity to kind of shift the cancer treatment paradigm, from a kind of the traditional way of a treatment into more of a precision medicine model where treatment is tailored, towards the constitutional DNA of the individual. That being said, it offers an empowering and more informative approach into how the patient needs to be treated in a personalized manner. And that could be, involving three major kind of areas of a treatment. The first area is the what we call it targeted therapy selection. Okay, and that's by itself is very wide, and there is a lot of details about it. However, I will just cover the two major treatment or targeted treatments that could be determined by germline genetic testing. One of them is something called PARP inhibitors. And those actually is a treatment that is offered for a certain population of patients who have a cancer that is BRCA1 or BRCA2, positive for germline testing, and those are, as you know, are the most common mutated genes in hereditary breast and ovarian cancer. So those patients who have like breast cancer, ovarian, prostate, or pancreatic cancer with a mutation in BRCA1 or 2 are eligible for this kind of a treatment. And this treatment, interestingly, works on the some weakness in the cancer cells, where it actually blocks the alternative pathway for DNA repair. So targeting that for cancer cells and sparing normal cells will eventually lead to the death of these cancer cells. So this is one example. The other example is also a common hereditary cancer syndrome, which is Lynch syndrome. And Lynch syndrome is known to increase risk mainly for colon cancer or endometrial cancer. And those patients have something we call mismatch repair, repair. MMR, mismatch repair in the DNA, basically. And that, those kind of cells are visible to immune system, so they make them very good candidates for immune therapy. We call them checkpoint inhibitors. So these are the major examples for therapy selection. The second kind of application of germline testing is the choice of surgeries, or we call it surgery decision. And that could be in the form of risk-reducing surgeries, or could be in the form of prophylactic surgeries. One example of that is bilateral mastectomy for a patient, for example, who has a cancer in one breast, and then in terms of the decision, if they are BRCA positive, then they can be offered the option of bilateral mastectomy as a prophylactic approach for the patient to prevent the risk of the other breast to develop a cancer. Another example is for ovarian cancer risk, because we know that ovarian cancer is hard to detect. There is no good screening modality for it. So having a prophylactic, removal of ovaries or tubes can, also be very efficient for somebody who is gene positive, for BRCA, for example, or even for Lynch syndrome gene positive. And also, finally, it also affects the rest of the family in terms of, targeted testing for the rest of the family, and even in the design of the increased screening for those patients over time to prevent any future incidences of cancer. So those are basically some of them. And probably I would add one more, which is the modification of conventional treatments, especially for those who are positive for certain genes that make patients more sensitive to radiation. I would mention in this instance is those patients who are ATM positive gene. It's a kind of a cancer gene called ATM, and there is a gene called TB53, and those patients are abnormally very sensitive to radiation. So the doctor, it will give them an opportunity to modify treatment and lower the exposure for radiation, look for a more safer modalities of treatment. Yeah.
Thanks, Rifaat, for pointing out these. And I guess in summary, this genetic testing is not only helping for better cancer treatments, but also prevention of other types of cancers, and not for the patients alone, but also for their families. So thank you. And what we are increasingly seeing, which is good news, that there is a lot of genetic testing which is being done because of increasing awareness of this type of germline genetic testing in the population, and also amongst the physicians and the other clinicians. However, we sometimes see patients coming to our clinics with the reports where they're not sure of what to do with the results, because perhaps they were not seen by a genetic counselor prior to the test. And so that brings me to my next question. What really is the role of a genetic counselor in terms of pre-test and post-test counseling?
Yes. Absolutely, Dr. Fawad. Like you said, I think genetic counselors now do play a crucial role in patient care, and I think this is why we're two genetic counselors at CTAD currently, and hopefully more to come with time. But I think mainly the genetic counselor is here, first of all, to order the right test for the right patients. Genetic testings are not all the same, and they're not all appropriate for the same patient. It really depends on multiple criteria. So we are here to assess what's the best genetic testing for that specific person. The other thing is also to interpret these results. When this variant come back to us, what does that variant mean? Was it assessed in the proper way? Was it classified in the proper way? Because we are all carriers of variants, but not all these variants are going to cause an increased risk of cancer. So the role of the genetic counselor is, first of all, to determine is this result reliable? Is this variant reliable? Can we actually use it to counsel this patient, and can we rely on it? So I think this is one of our major roles. The other thing is, of course, I would say, I would like to say, is that genetic testing doesn't just change one person's care. It also affects his whole family. It can protect entire families. So I would say counselors, genetic counselors, don't only deal with one person, they also deal with all of their family members, at least the ones they have access to. So a lot of the people actually who come into our clinics, and I think Rifaat and you as well can both relate to that, is that they tell us we're not necessarily doing this test for ourselves, we are doing it for our kids, we are doing it for our siblings, we are doing it also for the other people that we care about in our families. So our role also is to determine who in the family is supposed to also get a test, who is at a higher risk of having a certain germline genetic variant, for example, and also determine also a certain program, which is what also you also do in your high-risk clinic. So Another thing is that a lot of people who are carrier of these variants come to us to say, okay, what about our children? What can we do for them? It is important to note that it's not necessarily always recommended to test children when they are at a younger age. We usually wait until adulthood for them to take their own decision to do the testing or not. The other thing is that for example, a person who wants to have children but has a certain genetic predisposition, cancer variant, they can decide to go for embryo testing. And this is something that is not very known, but that is practiced commonly, where we can basically select embryos who are not carriers of a certain variant to avoid passing on the cancer predisposition variant to the offspring. So I would say the genetic counselor really does add a lot of value. They also allow the patient to know what they're signing up for. What does this test what is the test's implication? What does it mean for them and for their families? So we are lucky to be in a place where genetic counselors are valued, and I think that the role is very important. But I would say mainly the genetic counselors never work alone. We always work in a multidisciplinary team, which also adds a lot of value. We are not alone. We are always talking to oncologists. We are talking to surgeons. We are talking to nurses. We are talking to pathologists to ensure the best possible care for our patients.
Thanks for highlighting the importance of genetic counseling. And here at Cleveland Clinic Abu Dhabi, we are very fortunate to have a comprehensive genetic counseling program with our board-certified, very experienced genetic counselors who are working closely with the rest of the team in the Cancer Center and are part of our longevity medicine section in the Fatma bint Mubarak Center at Cleveland Clinic Abu Dhabi. We have been talking about germline genetic testing, and I think it would be time to talk about somatic tumor testing, which is looking at the DNA of the tumor cells. Rifaat, please tell us more about the importance of this type of testing and how can it be used in patient care?
Absolutely. Thank you, Dr. Fawad. So basically, we talk about somatic testing, or some people call it tumor testing or tumor NGS testing. We're talking about a DNA test that is targeting and specific to the DNA changes and alterations, of the tumor itself. So we're looking at the DNA that is confined to the tumor, which is different than the germline testing, which we test the DNA that are found in all of our cells that you're born with it. And usually the mutations that are, we call them somatic mutations or tumor mutations, are mutations that developed over time, they're acquired, and it is actually one mechanism of the tumor to develop into into the next stages of cancer are the accumulation of tumors. We call the accumulation of mutations, and those mutations, we call them driver mutations for the cancer. So really, to test those mutations in the tumor has a different purpose than germline testing, and the purpose of it for our oncologists is to look at the kind of the tumor, the behavior of it, and what is the best modality to treat such a tumor. So tumors are not all the same. They have different DNA or genetic signatures. So by knowing this kind of signature, it would give them better information how to deal with this kind of a tumor. And interestingly, that sometimes when you do somatic testing for our patients, there is the opportunity or the chances that we stumble upon germline mutations by doing that, actually. And the reason for that is when you're testing the tumor itself, it actually you're looking at the tumor DNA as long as also the original DNA of the individual, okay? And but we have to keep in mind that even though that this kind of testing can identify germline mutations, we have to be careful that there is a lot of caveats. And because this is not designed originally to detect germline mutations, we have to be careful because sometimes there is a lot of chances of false negative or false positive, especially that there's some labs who are doing tumor testing, they filter out germline mutations just to give maybe a simpler report, or because they assume that you already know about this mutation. So that's one thing. And sometimes what happens is also that a mutation that seems to be germline in a gene that is known to cause a known hereditary cancer syndrome, and with a high frequency in that a tumor, turns out to be just a somatic acquired mutation, although it seems as if it is a germline mutation. So we have to be careful and not depend on that to come up with conclusions, but rather use confirmatory testing, including germline testing on a blood sample, for example, to determine those mutations. And this adds more to the personalized kind of medicine approach, and how we, as Leia said, we work as a team, the multidisciplinary team, working with the pathologists, working with the oncologists, surgeons, and all of that to come up with the best management plan for our patients.
Well, I think that also highlights the most important piece of information, which is the genetic result and appropriate interpretation of
Absolutely.
these results by a certified genetic counselor.
It's not always straightforward.
And it's not straightforward. And then you also match the results with the clinical picture as a team, and that really makes it a team effort to focus on one most important person in this picture, and that is the patient.
The patient, yeah.
Leah, how do you use these results, these somatic tumor testing results, in the patient care?
So, like Rifaat said, so when we are testing the tumor, basically we are testing the genes that are in this tumor and not necessarily the germline genetics. So it can actually guide treatment. So this is why certain variants that are found in some tumors can help decide on what treatment is better for this particular tumor with these specific variants. So this really does really change the management or the treatment of a patient. The second thing is that sometimes when we do those somatic testing on the tumors, we can also determine basically why some treatments will be less efficient than others. So this really helps physicians or treating oncologists to be able to personalize, if we want to say, the treatment depending on a person's genetics or the tumor's genetics. So I would say like tumor testing is now done definitely more frequently because everybody is aware that it can really really help the management. The other thing is that, again, it's never a standalone result. It is really correlated to other aspects of the patient's needs and concerns at the time of treatment. So I would say all kinds of genetic testing are important. They just have different roles and different use at the moment of the testing. Yeah.
We're talking about different types of genetic testing. Yeah. Would like to come to our last question, and that is doing genetic testing to decide the efficacy of any medicine, whether it's cancer-related medicine or outside cancer-related treatments. Pharmacogenetics is another very important, very hot area in precision medicine. And here in Cleveland Clinic, Abu Dhabi, we do a lot of pharmacogenetic testing. So we are able to decide and guide our treatments for our patients in a better way. Can you share a few words about pharmacogenetic testing?
Absolutely, thank you so much. So pharmacogenetics, I would consider it as probably one of the widely used nowadays applications of precision medicine, pharmacogenetics. And in simple terms, pharmacogenetics is the study of DNA variations of individuals and to determine the individual's body's reaction, processing, and response to certain medications. We have to understand that we are, as a human beings, we have differences. And those genetic differences doesn't necessarily mean that you have a disease, but rather your reaction and your response to medications are not the same. Okay, so we are shifting away from the traditional approach of medicine and medicine prescribing from a one-size-fits-all into a more tailored, personalized approach of a treatment. And really, pharmacogenetics is the way to go when trying to be to adopt a smarter approach of prescribing medications. So basically what happens is that an individual is tested for so many, maybe like in the hundreds or thousands of markers in your DNA, and each marker is associated with a specific gene that is associated with a different response to certain medications. And so by doing that, we actually have a better understanding of each person's reaction to certain medications, including, we can predict toxicity of a certain medication. So if a certain person, for example, has a cancer treatment that is very, let's say, toxic to this person because of his genetic makeup, maybe the doctor needs maybe to adjust the dose, or they may need also to look maybe for an alternative treatment for this medication. Also, it increases the efficacy of that, and that could be done by modulating the dose. So now we're smarter, in trying to give the proper dose, which could be different from one person to another based on their genetic makeup, and that's really increases, the benefit for our patients and reduces the side effects of that medication. And it also changes the approach of trial and error. Historically, we know that doctors sometimes use certain medications and wait to see if it helps or not, and all of that. But now with the pharmacogenetics, we can know ahead of time, the proper medication, the proper dosing for that. Just to give one example, for a specific medication that is commonly used, and probably we use that for a lot of patients, even in your clinic, of high-risk clinic and other clinics, is tamoxifen. Tamoxifen is known to be a widely used medication for those women who are at high risk to develop breast cancer. And it works on blocking or inhibiting the effect of estrogen, which usually some breast cancer cells, they kind of feed on that and grow. And by blocking that, you reduce the female's risk of developing breast cancer. Tamoxifen has a different, I would say, processing or a metabolism rate, among different women. And by doing a specific genetic test for a gene called CYP2D6, and that gene actually affects the woman's rate of metabolizing that medication, because the medication itself, tamoxifen, is not by its original form, is not the active form for treatment. It's the metabolite that only converted in your liver by that CYP2D6 into a more active form, which is called endoxifen. And some people are, with a certain genetic makeup, are very slow metabolizer of that. So even if you give them medication, the benefit is very limited. However, for some people, they're fast metabolizer, which means that they get more exposure to that active form. So really knowing which the patient in which category they are, if they're fast metabolizer or slow metabolizers, will determine the best kind of dose to give those patients, either increasing or decreasing, to give the best benefits for our patients. This is kind of a summary of that. Of course, there is a lot of applications, a lot of hundreds of medications that actually have an application in pharmacogenetics. So just to give an idea of one of the most common, drugs that is used in oncology.
Well, thank you, Rifaat and Leah, for the very enlightening conversation today. We hope you enjoyed our conversation, and till we see you next time and Doc is in, a goodbye.